Hello everyone and welcome to our module on dermatomes and reflexes. Over here on the right side of the screen I've drawn a map of the human dermatome. So what do I mean when I say dermatomes? Well, recall that the spinal cord has spinal nerve roots that come out on each side of the body that carry both motor and sensory nerve fibers. Well, the muscles innervated by one particular spinal root are called the myotome for that spinal root, and the sensory skin areas innervated by one particular spinal root are called the dermatome. And this is a map of the dermatome over here on the right. Notice at the top that we have areas of skin labeled C2 and 3 and C3 and 4, and that's because these are the cervical spinal roots. That's why they're called C. Here in the middle we have ones labeled T for thoracic, and down at the bottom we have ones labeled L. So this map shows you which areas of the skin are sensed by which spinal nerve roots. Now you should be aware of where the nerve roots come out relative to this corresponding vertebrae, and to help you understand that I've drawn a diagram here on the left side of the screen. So right here is the C1 vertebrae indicated by this line right here, and the C1 nerve root comes out just above the C1 vertebrae. We then have all the cervical nerve roots coming out above the corresponding vertebrae until we get down to C7. C7 comes out above the C7 vertebrae, and then there is an eighth cervical nerve called C8 which comes out below C7. After that we have the T1 vertebrae, and then the T1 nerve root comes out below T1. And from that point on, all the nerve roots come out below the corresponding vertebrae. A couple of features of this system to understand. The cervical nerve roots all come out above the corresponding vertebrae except for C8. After that, all the nerve roots come out below the corresponding vertebrae. Also note that there are only 7 vertebrae in the cervical region, but there are 8 cervical nerves. And then one final peculiar thing to note about this system is there is no C1 dermatome, and that's because C1 is purely a motor nerve root and doesn't have any sensory information. Okay, let's talk about some special spinal nerves that you should be aware of. The first one is the phrenic nerve, and it's very important. It innervates the diaphragm and helps us breathe. It arises from C3 to C5. Some people remember this by saying C3 to C5 keeps the diaphragm alive. And a special feature of this nerve is that when the diaphragm gets irritated, patients will often sense referred pain to their shoulder because C3 and C5 also innervate the shoulder. A classic example is a patient who has gallbladder disease. They will sometimes complain of pain in their shoulder, and this is called referred pain. Also, patients who have lower lung masses can sometimes have the phrenic nerve get irritated, and they can feel a sensation of pain in their shoulder. Irritation of the phrenic nerve also causes dyspnea because you can't move the diaphragm the way you would like, and it can also cause hiccups. Sometimes patients get the phrenic nerve cut during surgery, particularly thoracic or cardiac surgery, and after this they can have shortness of breath and elevation of one half of their diaphragm from loss of that phrenic nerve. Another important nerve to know about is T10, and this is the level of the umbilicus, or what most people call the belly button. And this is where patients with appendicitis will sense referred pain. The initial symptoms of appendicitis are only sensed by visceral fibers, and these are transmitted through T10, and so the body thinks that the pain is coming from the belly button. Patients will initially complain of colicky pain in their belly button. As the appendicitis gets worse, the parietal perineum will start to get inflamed, and then the pain will become more specific and move over to the right lower quadrant where the appendix is. Another important thing to know about the dermatomes is that they are involved in the pathology of herpes zoster, which is also called shingles. So let's review the varicella zoster virus. This is a herpes virus, and a primary infection with the varicella zoster virus is called chickenpox, and that usually happens in children, especially if they haven't been vaccinated. They'll get fever, pharyngitis, and a vesicular rash. Now, once you've been infected with varicella zoster, the virus can lie dormant in your body and then later reactivate. And when it reactivates, that's what's called shingles. And many people refer to shingles as herpes zoster, so you just need to know that vocabulary. So as I said, the virus can lie dormant in the dorsal root ganglia of the body. And when it reemerges, you will get a rash that will spread from the dorsal root ganglia along the dermatome. The rash won't cross the midline because the dermatome doesn't cross the midline. And this commonly happens in patients who are elderly or those who are immunocompromised. These are people where the virus is able to reactivate. And here's a picture of the herpes zoster virus in an affected patient. So you can see it's spreading along the dermatome here to the middle of the chest. It's not crossing the midline because that's another dermatome on the other side. And it can affect any dermatome. It can sometimes be in the face, it can sometimes be on the back, but it will always be a dermatome. So next we're going to talk about reflexes, and to do that let's briefly review what a reflex arc is. You need to understand that the body wants to maintain a moderate amount of tension in all the muscles at all times, and it wants to do this without having to go through the brain because that's a long, cumbersome process. So it does this through reflexes, and here's an example of the patellar reflex. So this is the patella, which is the kneecap right here, and it's connected to the quadriceps muscle right here. So the spinal cord is constantly sensing the amount of tension in the quadriceps via a sensory nerve that sends signals to the spinal cord. And then the spinal cord reacts by sending back signals through a motor nerve to keep the quadriceps contracted at a basal level. And it's able to do this all at the level of the spinal cord without having to send signals up and down to the brain. Now you can test this arc by tapping with your hammer on the patella right here. This will stretch the quadriceps muscle, which will be sensed by the spinal cord, and it will send signals out to contract the quadriceps muscle, and the result is that the leg will kick up. So when you tap on the patella, you are testing this entire system here, and you can test different muscles to get the sense of whether different sensory and motor nerve roots are working. So here are the 4 clinically tested reflexes that you will see come up when you study the clinical examination or when you examine patients. The biceps reflex is tested by placing your thumb usually on the base of the biceps and then tapping it with a reflex hammer. And this tests nerve function at the level of the C5 root. You can also test the triceps muscle in a similar way on the arm, and this tests C7. When you tap on the kneecap or the patella reflex and make the leg kick out, this tests the L4 level. And then when you tap on the ankle or the Achilles tendon and you see the ankle jerk, this is called the ankle jerk reflex, this is testing S1. Reflexes are described using a 5-point system, and this is especially important for USMLE exams. On exams, they will give you a number to tell you how vigorous the reflex is. So a 0 reflex means there's no reflex present, 1+ means it's diminished, 2+ is a normal reflex, 3+ is a brisk reflex, 4+ is very brisk, and 5+ means there's sustained contraction of the muscle. Now importantly, we'll talk about this in other modules, but when you have a lower motor neuron lesion in the central nervous system, you get diminished reflexes, and that will be described for you in board questions as a 1+ reflex. When you have an upper motor neuron lesion, you get brisk reflex, or sometimes called hyperreflexia, and this will be described in a question as a 3+ reflex. So become very familiar with this scale so that when you're told what the reflex is on a number scale, you can tell whether it's diminished or brisk. Let's talk about nerve root syndromes. These are syndromes of pain and motor weakness that occur in the lower extremities when one of the spinal nerve roots is compressed or damaged. This typically occurs when an intervertebral disc herniates. So for example, if the intervertebral disc between L4 and L5 herniates, it will compress the L5 spinal nerve root, and this will give a typical syndrome with a constellation of symptoms. If the L5-S1 intervertebral disc herniates, it will compress S1. In other words, the nerve root below the level of the herniated disc is the one that gets damaged. The L5 nerve root syndrome is the most common nerve root syndrome that occurs in herniated discs. It results in back pain that goes down the lateral side of the leg. The foot strength is reduced, especially for dorsiflexion. The reflexes will be normal. The second most common nerve root syndrome involves S1 when the L5-S1 disc herniates. In this syndrome, there's pain down the back of the leg, not the lateral leg. There's weakness to plantar flexion, and importantly, the ankle reflex is lost. And if you're trying to remember these for step 1 of your boards, just remember that the ankle reflex is lost in an S1 nerve root syndrome. The reflexes are normal in the L5 syndrome. That will usually help you distinguish the two in a board question. It's very high yield for the USMLE to understand the Babinski reflex or the Babinski sign. This is also called the plantar reflex. And the way you test this reflex is by taking a blunt object and stroking the bottom of a patient's foot upward. A normal response is for the toes to plantar flex or point downward like this. An abnormal response is for the toes to dorsiflex or point upward. And the reason this reflex is so important is because an abnormal Babinski reflex or a positive Babinski sign, meaning the toes pointing upward, tells you that there is upper motor neuron damage. The upper motor neurons suppress the upward going toes from this reflex and they make the toes go down. When they're damaged, you get an upward reflex. You can also see an upward reflex in normal infants up to a year old. There's incomplete myelination of their fibers, and therefore they have a Babinski sign. In board questions, you'll be shown patients who have motor dysfunction, and they'll tell you what the Babinski sign shows, and that lets you decide whether it's an upper or lower motor neuron problem. There are a couple of what are called primitive reflexes that you should know. These are reflexes that are all present at birth in normal babies, but they go away within a year. Babies who don't have these can be sick, so that's why they're important. They're also important because pathology in adults can cause a reemergence of these reflexes. When your frontal lobe matures, it makes these reflexes go away. So patients who have frontal lobe pathology will see a reemergence of their primitive reflexes. And there are 6 key reflexes that you should know: the Moro, the rooting, the sucking, the palmar, the plantar, and the glant. The Moro reflex is also called the startle reflex, and that's because babies will sometimes do this when they're startled, for example, by a loud noise. The way you test the Moro reflex is to lie the baby on its back and then lift it just very slightly off the bed and then let go. And the baby will then do 3 things. It will first spread its arms, then it will unspread its arms and bring them back towards the midline, and then it will start to cry. And this is a normal Moro reflex. And you can also see this when babies are startled or surprised. It goes away in the first year of life. The other 5 primitive reflexes are here, so let's talk about each one. The rooting reflex is when you stroke the baby's cheek. It turns toward the side of the stroke. The sucking reflex is how the baby will suck anything that's put on the roof of its mouth, and is usually done by putting a finger in the mouth of the baby. A palmar reflex is when you stroke a baby's palms, its fingers will grasp your finger. Plantar reflex is the Babinski reflex, which we just talked about, and that's normal up to a year. And for the glant reflex, you sort of hold the baby under your arm in the air and you stroke its back, and it will swing its legs from one side to the other. And when you do a pediatrics rotation, you will go to the newborn nursery and check out new babies, and you will look for facial and body abnormalities, but you're also going to check all these reflexes to make sure that they're present. And that concludes our module on dermatomes and reflexes.